Hey everyone! If you're a nursing student, you already know that pediatrics is a whole different world. So today we're going to build a field guide, a sort of toolkit for tackling the most common communicable diseases you'll see in kids. And we're going to start with a scenario you are guaranteed to encounter. Okay, so picture it. You walk into your patient's room. You've got a little one with a fever, a cough, and some kind of mystery rash. What's your first move? Where do you even begin? I mean, this could be any one of a dozen different things, right? This is exactly where your nursing brain has to kick into high gear. So let's break down how we solve this puzzle, one step at a time.
And that brings us to our first section, the pediatric puzzle. And it's a puzzle because so many of these childhood illnesses start out looking almost identical. That makes your initial assessment absolutely critical.
A lot of these diseases kick off with what's called a prodromal phase. It's that period of vague, nonspecific symptoms. We're talking a runny nose, a little cough, a fever, just general malaise, that feeling of being unwell. You'll also see kids get really irritable, and parents will often say their behavior just changed. Since these clues are so general, having a systematic way to think about them is going to be your best friend.
So before we even start trying to pinpoint the exact disease, we need to put on our public health hats for a second. Let's move into Section 2, Transmission and Prevention. We have to figure out how these things spread because that tells us exactly what we need to do first to keep everyone else safe.
This table is awesome because it organizes everything by how it gets around. You've got your droplet spread illnesses like pertussis. Then you have contact-based ones like pink eye. And then there are the really tricky airborne diseases like measles. For those, you need an airborne isolation room, STAT. And of course, some things, like mono, spread through saliva. Just knowing the potential route is your first step to containing it.
But really, what's our single most powerful tool on this whole fight? It's right here, immunization. We can't talk about treating these diseases without talking about preventing them in the first place. I mean, for things like measles, chickenpox, and pertussis, vaccines are, hands down, the best public health measure we have for protecting not just one kid, but the entire community.
All right, Section 3, decoding the signs. This is where the real detective work begins. The kid is safely in isolation, and now it's our job to hunt for those specific hallmark clues that are going to crack the case and give us a diagnosis.
First up, let's clear up a super common point of confusion, rubeola versus rubella. People call them both measles, but they are totally different. Rubeola, or regular measles, hits you hard with a fever, cough, and conjunctivitis. Rubella, or German measles, can be so mild you barely notice it. But here's the key takeaway. The complications. Rubeola can cause serious brain inflammation, while rubella can be absolutely devastating if a pregnant woman gets it.
And this is why your pen light is one of your most important tools. If you even think it might be measles, you need to look inside the mouth for Koplik spots. They're these tiny little red spots with a bluish-white center, kind of like grains of salt. And the crucial part? They show up before the body rash, which gives you a huge head start on getting that kid into proper isolation.
All right, next clue. If a child walks in with these fiery red cheeks, it literally looks like they've been slapped, your brain should immediately jump to Fifth's disease. Now here's a really important teaching point for parents. By the time this classic rash shows up, the child usually isn't contagious anymore. That's a huge relief for them to hear.
Okay, here's another telltale sign. And again, we're looking in the mouth. With scarlet fever, you'll see what we call a strawberry tongue. It's this white-coated tongue with swollen red bumps poking through. This is a dead giveaway that you're dealing with the same bacteria that causes strep throat. And that tells you one thing for sure. This kid needs antibiotics.
Now the key to spotting varicella, or chickenpox, isn't looking at one single spot. It's looking at the whole picture. The rash is what we call polymorphic. That just means you'll see lesions in all different stages, all at the same time. You'll see new little bumps, fluid-filled blisters, and old crusty scabs, all next to each other. That's unique. And remember, that child is contagious until every single one of those lesions is crusted over.
And what about the dreaded pink eye? How do you tell if it's viral or bacterial? Well, it all comes down to the discharge. If it's watery and clear, you're probably looking at a virus, and you just need to provide supportive care. But if it's thick, goopy, yellow-green gunk that's crusting the eye shut in the morning, that's screaming bacterial infection, and that means they're going to need antibacterial eye drops.
So we've gathered our clues, we have a pretty good idea what's going on, so what do we do about it? Let's get into Section 4, the Nurse's Action Plan. This is where we lay out our essential interventions.
In the hospital, our game plan really boils down to 3 core actions. Number 1, initiate isolation immediately, based on what you think the transmission route is. Number 2, provide supportive care. Our job is to manage their symptoms and just keep them as comfortable as possible. And number 3, monitor for complications. We've got to watch them like a hawk for any signs that things are getting worse.
And supportive care is a big term, right? It's really a whole toolkit you have. If there's a fever, we're giving acetaminophen. For an itchy chickenpox rash, things like calamine lotion and oatmeal baths are lifesavers. Got painful mouth sores from hand, foot, and mouth? We can offer soft foods and numbing throat sprays. And for an infant struggling with that horrible cough from pertussis, cool, humidified air and having suction ready to go is absolutely vital.
This right here is where your sharp assessment skills can literally save a life. These are the red flags we cannot afford to miss. An infant with pertussis who starts struggling to breathe, that's an emergency. A child with measles who suddenly becomes confused or lethargic. You have to think encephalitis and escalate care immediately. These are the critical changes you have to be watching for.
So the child is getting better, the discharge orders are in. But our job is not done. In fact, you could argue the most important part is just getting started. That brings us to Section 5, from hospital to home.
Think of this as your discharge teaching checklist. You have to make sure the parents walk out that door feeling confident. They need to know how to manage a fever, how to keep their child hydrated, and how important hand washing is. And maybe the most critical piece of all, they need to know exactly what signs to watch for that mean they need to call the doctor right away. Your clear communication here is everything.
In this quote, it hits the nail on the head. It really sums up the whole thing. As a pediatric nurse, you're so much more than a clinician. You're an educator. You're a public health advocate. When you empower one family with the right knowledge, you're not just helping their child get better, you're helping protect the entire community.
So we'll leave you with this final question to think about. You can identify all the signs, you can create the most perfect textbook plan of care, but it's all useless if an anxious, scared parent doesn't trust you enough to follow it at home. And that is the art of nursing, connecting with people when they're at their most vulnerable. So as you go forward, think about that. How will you turn your clinical knowledge into a parent's confidence? Because that is what makes a great pediatric nurse.